4 anticoagulation agents are available for acute coronary syndrome, each with specific clinical scenarios where it is preferred, and clinicians must choose only one anticoagulant to avoid excessive bleeding risk. Unfractionated heparin, UFH, is the preferred choice for patients proceeding to cardiac catheterization within hours because it has a short half-life, allowing for immediate reversal if needed during the procedure. And it is also the only option safe in severe renal failure. Creatinine clearance less than 30 milliliters per minute, since it is not renally cleared. Enoxaparin, a low molecular weight heparin, is preferred for conservative medical management in patients with normal renal function because it provides more predictable anticoagulation without requiring monitoring and has a lower risk of heparin-induced thrombocytopenia. Fondaparinux offers the lowest overall bleeding risk and is excellent for conservative management, but it is absolutely contraindicated in patients going to PCI due to the risk of catheter thrombosis. Bivalirudin, a direct thrombin inhibitor, is used specifically during percutaneous coronary intervention procedures and offers lower bleeding rates compared to the combination of heparin plus glycoprotein 2B/3A inhibitors. The key principle is selecting the single most appropriate agent based on whether the patient is proceeding to immediate intervention or being managed conservatively, renal function status, and bleeding risk considerations. Enoxaparin, a low molecular weight heparin, is absolutely contraindicated in this patient with a creatinine clearance of 25 milliliters per minute because it is primarily cleared by the kidneys and accumulates to dangerous levels in renal insufficiency. The threshold for contraindication is a creatinine clearance below 30 milliliters per minute, as patients with severe renal impairment cannot adequately eliminate the drug, leading to excessive anticoagulation and significantly increased bleeding risk due to unpredictable drug accumulation. In patients with severe renal failure requiring anticoagulation for acute coronary syndrome, unfractionated heparin, UFH, is the appropriate alternative because it is metabolized by the reticuloendothelial system rather than the kidneys, making it safe to use regardless of renal function. However, unlike enoxaparin, which requires no monitoring, UFH necessitates regular activated partial thromboplastin time, a PTT, monitoring to ensure therapeutic anticoagulation while avoiding excessive levels, adding a layer of complexity, but providing the necessary safety profile in renal failure patients. Fondaparinux is absolutely contraindicated in patients proceeding to percutaneous coronary intervention due to an increased risk of catheter thrombosis during the procedure, which can lead to catastrophic complications including acute myocardial infarction or procedural failure. Despite having the lowest overall bleeding risk among all anticoagulation options, making it an attractive choice from a safety standpoint, fondaparinux lacks sufficient anti-IIA thrombin activity and provides inadequate protection against clot formation on interventional equipment such as guide catheters, guide wires, and balloon catheters used during PCI. This makes fondaparinux ideal for conservative or medical management of NSTEMI/unstable angina in patients who are not proceeding to catheterization, where its excellent bleeding profile is advantageous for prolonged anticoagulation. The critical exam trap is recognizing that fondaparinux equals conservative management only. If there is any possibility the patient will undergo cardiac catheterization, even in a delayed fashion, fondaparinux should not be selected, and alternative anticoagulants, such as unfractionated heparin, enoxaparin, or bivalirudin, should be chosen instead. Beta blockers should be administered orally within 24 hours of presentation in acute coronary syndrome patients who are hemodynamically stable, representing an important shift from historical practice that emphasized immediate administration. The preferred and only appropriate route is oral administration, not intravenous, as this allows for gradual titration and avoids the hemodynamic instability that can occur with rapid IV dosing. A critical exam trap that frequently appears on board examinations is the outdated practice of giving intravenous beta blockers early in the acute phase of myocardial infarction. This approach has been definitively shown to be associated with worse outcomes, including increased risk of cardiogenic shock, heart block, and death, particularly in patients who are not yet fully stabilized. The key principle is to wait until the patient is stable, meaning they have adequate blood pressure, heart rate, and no signs of acute decompensated heart failure or other contraindications, before initiating oral beta blocker therapy within the first 24 hours. This approach maximizes the mortality benefit of beta blockade while avoiding the hemodynamic complications that plagued early aggressive IV protocols. Beta blockers have several absolute contraindications in acute coronary syndrome that must be carefully assessed before administration, as giving beta blockers in these settings can be catastrophic. Active or decompensated heart failure is a contraindication because beta blockers' negative inotropic effects would further reduce cardiac output and worsen pulmonary congestion. Bradycardia with heart rate less than 60 beats per minute contraindicates beta blockers due to risk of severe symptomatic bradycardia or asystole. Hypotension with systolic blood pressure below 90 millimeters of mercury is a contraindication, as beta blockers would further lower blood pressure and compromise organ perfusion. High-degree atrioventricular block, second-degree, type 2, or third-degree, contraindicates beta blockers because they slow AV nodal conduction and could precipitate complete heart block, requiring emergency pacing. Severe reactive airway disease such as asthma is a contraindication, as beta blockers can cause life-threatening bronchospasm through beta-2 receptor blockade. Most critically for board examinations, cocaine-induced myocardial infarction is an absolute contraindication because beta blockers cause unopposed alpha-adrenergic stimulation, leading to severe coronary vasospasm, hypertension, and worsening ischemia. In cocaine MI, benzodiazepines should be used instead as first-line therapy. Beta blockers are absolutely contraindicated in cocaine-induced myocardial infarction because they create a dangerous state of unopposed alpha-adrenergic stimulation that severely worsens the patient's condition. Cocaine simultaneously stimulates both alpha and beta adrenergic receptors. When beta blockers are administered, they block the beneficial beta-2 mediated vasodilation in coronary arteries, leaving alpha adrenergic vasoconstriction unopposed. This results in profound coronary artery vasospasm that dramatically worsens myocardial ischemia, paradoxically increases blood pressure through unopposed peripheral vasoconstriction, and can precipitate complete coronary occlusion or malignant arrhythmias. The correct management approach for cocaine-induced MI centers on benzodiazepines as first-line therapy to reduce sympathetic outflow and anxiety, combined with aspirin for antiplatelet effects, nitroglycerin for direct coronary vasodilation, and calcium channel blockers if vasospasm persists despite initial measures. This represents a critical high-yield exam trap, as candidates may reflexively include beta blockers in their ACS management algorithm without recognizing the unique pathophysiology of cocaine-induced coronary vasospasm that makes beta blockade not just ineffective, but actively harmful. High-intensity statin therapy should be initiated immediately in all patients with acute coronary syndrome, regardless of their baseline LDL cholesterol level, using either atorvastatin 80 mg or rosuvastatin 40 mg daily. This represents a paradigm shift from traditional lipid management, as the indication for statin therapy in ACS is not based on lipid levels, but rather on the acute plaque stabilizing and anti-inflammatory effects that provide benefit within the first days after the event. The mechanisms of benefit extend far beyond simple cholesterol reduction and include stabilization of vulnerable atherosclerotic plaques to prevent rupture, reduction of systemic and vascular inflammation, improvement in endothelial function, and antithrombotic effects, all of which contribute to measurable mortality reduction even in the acute phase. This therapy should be given universally to all ACS patients as part of initial management, with only two absolute contraindications: active hepatitis, due to risk of hepatotoxicity, and pregnancy, due to teratogenic effects. The principle is that every ACS patient benefits from high-intensity statin therapy started immediately, independent of their lipid profile, making it a non-negotiable component of evidence-based ACS care. Reperfusion therapy and ST elevation. Myocardial infarction is governed by strict time goals that reflect the critical relationship between treatment delay and myocardial salvage, captured in the mantra, "Time is muscle." For primary percutaneous coronary intervention, the gold standard reperfusion strategy. The door-to-balloon time must be less than 90 minutes from initial hospital presentation to first balloon inflation in the coronary artery. If the patient requires transfer to a PCI-capable facility, this window extends slightly to less than 120 minutes to account for transport time. When thrombolytic therapy is chosen as the reperfusion strategy, typically because PCI is not available within the acceptable time frame, the door-to-needle time must be less than 30 minutes from presentation to administration of the fibrinolytic agent. These aggressive time targets are based on compelling evidence that every minute of delay in reperfusion directly translates to larger infarct size, greater loss of viable myocardium, increased risk of complications including heart failure and arrhythmias, and higher mortality rates. The underlying principle is that acute coronary occlusion in STEMI creates an expanding zone of irreversible myocardial necrosis that can only be limited by rapid restoration of blood flow, making speed of reperfusion the single most important determinant of outcomes. Absolute contraindications to thrombolytic therapy include any history of prior intracranial hemorrhage, regardless of how long ago it occurred. Patients with known intracranial vascular malformations or tumors are also excluded. Recent neurological events are contraindications as well, specifically ischemic stroke within the past 3 months, significant closed head trauma within 3 months, or any intracranial or spinal surgery within 2 months. Additionally, thrombolytics are absolutely contraindicated in patients with active bleeding, bleeding diathesis, or suspected aortic dissection. Following successful thrombolytic administration for STEMI, clinical monitoring for signs of reperfusion is essential, including resolution of chest pain and normalization of ST segment elevation on serial ECGs, which indicates successful restoration of coronary blood flow. However, even when thrombolysis appears successful based on these reperfusion markers, current guidelines mandate proceeding to cardiac catheterization within 24 hours as part of the pharmacoinvasive strategy. This approach recognizes that while thrombolytics can restore initial blood flow, they do not address the underlying ruptured atherosclerotic plaque that caused the occlusion, and early angiography with intervention allows for definitive treatment of the culprit lesion, assessment of other coronary disease, and optimization of long-term outcomes. The pharmacoinvasive strategy has been shown to reduce reinfarction rates and improve survival compared to thrombolytics alone. In contrast, if thrombolysis fails, evidenced by persistent chest pain and continued ST elevation 60 to 90 minutes after thrombolytic administration, the patient requires immediate rescue PCI without the 24-hour waiting period, as ongoing coronary occlusion demands urgent mechanical revascularization to salvage threatened myocardium and prevent further damage.